Thank you very much for Dr. Nizar for your introductions. It's my pleasure to be with you today and have discussions regarding the RSV and what is the availability of prevention measures to prevent the RSV infections. This is the disclaimer that I'm receiving honors from the JSK regarding this. And then simply, the RSV, the message that we'd like to conclude by end of this presentation, that elderly people, more than 60, they are targeted in our program to be vaccinated, and we are hoping to prevent the infection among them. They are high risk. If they're not vaccinated, it would be risky to develop comorbidity and leading to the admission and possibly to the death. The RSV, the respiratory syncytial virus, considered as a common contagious viral infections that lead to the moderate to severe, unfortunately, lower respiratory infections. And all the categories group of the community would be risky, definitely considered as a children disease, but the elderly people, as because of the immunosenescence and losing of the immunity, would be risky to get the disease, especially as we have now the carrier for the disease, which is the children. And we know that in our community, that's the elderly people, they always sit with their the children, and they could be risk for the disease. Again, for the adults and those having a chronic disease, it would be highly risky to get this vaccine. This is a droplet transmission virus, and would be shedding a virus for 6 to 8 days, and possibly that will be increased shedding time among those with immunocompromised or elderly people. So imagine that those people will have an infection. How can we shed the virus to others? And in epidemiology, we consider, if you remember, that using COVID, the R0 or the reproduction number, that's if someone infected by the RSV, he or she could be infected almost 3 of people for this virus. And imagine 3 will be infected 9 will be infected 18, so 27, etc. So that's definitely would be highly spread, especially among special season of the year that we have, especially in the winter, if this is correct about the epidemiology season of the RSV. It's the structure of the RSV, which is what always very important to understand the pathophysiologies of the disease, mainly having 2 proteins, the F protein and G protein. And we have these 2 types of the RSV. We have A and B. This is the basic that we have to keep it in your mind when we are talking about the vaccines. Simply, someone infected, getting the infection through the nasopharyngeals or conjunctivitis, so that will be spread, having the intracellular and humoral immunity, causing cytotoxics, leading to the necrosis of inside the lung, causing, unfortunately, the upper and lower respiratory infections, leading sometimes to the cardiac morbidity. The symptoms for those, anyone have RSV would have, upper respiratory infection in general, as rhinorrhea, nasal congestion, sneezing, cough, and definitely you could have the consequences of the lower respiratory infections, leading to the pneumonia and exacerbate, unfortunately, the COPD and then bronchitis. Definitely, as we could lead to the cardiovascular consequences. As an example of that, heart failure, myocardial infarction could be expected among those patients. Well, unfortunately, we don't have, to be honest, any local data, but we are sharing some of the global data that this is among, I think, more than, this is in industrial cities, industrial countries that reported such of the surveillance of data that almost in 2019, almost 5 million of people having the disease, and almost half of those hospitalized. Imagine how those people will affect the service and occupy the bed for something that could be prevented. Unfortunately, 33,000 died because of the RSV virus. The looking of the age risk elderly people, well known in that when they classify the epidemiological group of those highly infected and getting the consequent disease, consider those having the elderly people and having comorbidity disease, especially for the respiratory and cardiac disease. As how that the people having a COPD would be admitted when they have RSV, the risk would be increased almost 13 times. They could be hospitalized to the hospital because of RSV if they are well known a case of COPD. Asthma, it reached the 4 times. For the CV disease, 8 times, and diabetes, which is here in the kingdom, unfortunately, it's considered the endemic disease. And we could, if someone, elderly people, an endemic could reach to the 11 times that could be admitted, and because of the RSV vaccine virus. So simply, we have this. That's the risk could be increased with the elderly people. We have a low, I would say, we don't have, to be honest, any data or surveillance data regarding the RSV to understand the burden. However, I'm sure everyone have a story and have some of them, colleagues that thought that there is increase of cases of RSV cases if that available in your hospitals during specific month. For example, in some hospitals, they have it reported in November and December more in comparison to the other months. And the shedding of the virus, how can people that with this reproductive number that could be decrease the risk of them shedding the virus to other, and the droplets transmission of the virus to other would be risky and spread among the community. So we have to think and we have to find solutions how we can increase the herd immunity and protect those high risk groups, especially with those elderly and having a comorbidity. This is just a comparison between how the hospitalizations in comparison to the flu. I know the flu is one of them, a disease that we have to fight. We have to educate people the importance of the vaccination. And this is a message important actually for the colleagues, healthcare workers. We have to be considered one of the our yearly vaccination program that to every healthcare workers to receive the flu vaccine to protect themselves, protect their families, to protect the patients, especially those patients that we deal with them that are immunocompromised. However, we can see in these slides that they with that RSV, it's more risky than flu that we are focused now on the vaccination in regard of the hospital utilization and respiratory outcome and the survival, and reach the 2 times risky that people could be admitted because of the of RSV in comparison to the flu. So what is the solution in our hand now? We have what they call the Arexvy, which is a vaccine that would be help to prevent the RSV. This is the vaccine that would be targeted for the elderly people above 60 years and definitely will help to reduce the risk of lower respiratory infections. Simply will depend on the structure that we talk about F protein and G protein, and it's adjuvant to help in the way how can we introduce the intracellular and the humoral immunity for production of the T cells and B cells to have immunity against of the RSV. Both A and B would be this vaccine would be have efficacy against them. This is the name the generic name for the vaccine, which is RSV Pre-F3 vaccines. It is adjuvant vaccines. We're having the AS01 as adjuvant system that will help to accelerate and to boost the immunity to help in production of the T cells and B cells, both systems. So that will include the cellular immunity. Definitely that will give a good protection, as that is promised on the studies that we have in our hands. This is the clinical trial that studied actually the immunogenicity, the safety, and how it's the protective level of the vaccine that help to fight such a disease. They conducted the study almost in 17 countries, and they recruited almost 24,000 people. They distributed in the 2 groups, group as receiving a placebo vaccines and the other receive the RSV vaccines. Almost the RSV vaccines received in among 12. And they found a good, we will share some of the data in the next slide. So the first endpoint, which is the primary one, to understand the efficacy of the vaccine after 1 year once they receive the vaccine. The next year, what they did actually, they distribute those receiving the vaccine to two groups. The first group, we revaccinate them again to see if there is any effect or give a boost or booster dose for those receiving the first dose. And the other group, they monitor them to see what is the efficacy of the vaccine. And both of these endpoint have been reported and published, and they expect also to publish soon a new data regard once they complete 3 years of this intervention. So this is just the social demographic data for those participate. Majority of them, I would say, above 65, which is the mean of the group, 69, and 52 female with the different races, with the different regions around the world, as the north and hemispheres, and also include the people from the community and home care. Again, they consider the different people in the different actually groups to consider those having comorbidity to include in this study. So basically, what the first endpoint, they found that the efficacy of the vaccine after 1 year, it reached the 82 to reduce the risk of the RSV and lower respiratory infections, and reached to the 94% with those having comorbidity. Definitely, that's according to what we discussed before. That will help with helping the health system and helping people to be having, not to be risky for such a difficult virus. They found also the efficacy to increase with those to prevent the severe lower respiratory tract infections, and they reach the 94% as efficacy, and also with mild to moderate lower respiratory infection to the 82%. The age, it's associated with once people, higher age means higher protective. Unfortunately, the percentage of people that are above 80, there is a good number of people that recruited in the study to give a real correlation and association of this. However, for those 70, it reached to 93, and in those between 60 to 69 to reach to the 81. The comorbidity, whenever there is a comorbidity, the efficacy will be increased. So definitely those having comorbidity would be considered a high-risk group, and we have targeted, to be honest, if we have a less available vaccine, to be directed for those groups. There is no difference between the two different RSV when they receive the vaccine, and they teach the same effects for the vaccine for both, for the upper respiratory infection and lower respiratory infection. Okay, thank you. I will do inshallah in 2 minutes. So the mainly safety that's profiled, it's tolerated and with a good comply to those people has been vaccinated. However, they reported some of them side effects at the local, at the general. So reported the pain, erythema, and swelling in comparison to the placebo group, and they were systematically reported fatigue, malaise, and headache, arthalgia in comparison to the placebo. They also in the study that they include the flu, as you know, that there is a possibility to be included in the winter season vaccination or the respiratory vaccination. So it can be given with good toleration with the flu vaccine. However, the studies have been conducted with the inactive and conjugated quadrivalent vaccine, so not a live vaccine. So the conclusion and summary of this talk that I will share it with you, the RSV, it's something that we have to fight. It's common among those 60 and above, especially with those having comorbidity, the risk to be having, admitted and could be die. That would be theoretically there. We have now a good or effective vaccine reach the 94 to prevent such infections. And there's a report, and still we could have after 2-3 months the final report of the studies about a good tolerate and compliance to the to the RSV vaccine. This is what I have, and thank you.